Good afternoon and welcome to What's Up, Doc. My name is Tia Teriak and I'm with the Concord Hospital Trust. We have a wonderful presentation for you today. However, I want to start out by announcing some great news. The Walker Lecture Fund is now the official sponsor of our What's Up, Doc monthly lecture series. The Walker Lecture Fund was established in 1896 by Abigail Walker, the widow of Timothy Walker. Mr. and Mrs. Walker were lifelong residents of Concord. Their fund was established to provide free lectures on the subjects regarding history, literature, art, or science, which makes them a perfect sponsor for What's Up, Doc, which is our series of monthly lectures dedicated to providing the latest information on healthcare, treatment options, and providers here at Concord Hospital. Today, we welcome back Dr. K. She will share with you how to pronounce her name. We just affectionately call her Dr. K to save us all the embarrassment. Let me just share a couple of highlights from Dr. K's professional background. After receiving her master's degree in biology, Dr. K went on. She attended Boone Schaft School of Medicine at Wright State University in Ohio. She completed her residency at the University of Arizona School of Medicine, and then she completed a fellowship at the University of Louisville School of Medicine. And then she went on and she did an aesthetic and reconstructive breast fellowship with Dr. Dennis Hammond in Grand Rapids, Michigan. Dr. K is board certified in plastic surgery. She joined the Concord Hospital family in 2019. Please join me in welcoming Dr. K.
Thank you very much. Good afternoon, everyone. My name is Emese Kalnoki-Kis, also known as Dr. K. I am a plastic and reconstructive surgeon here with Concord Hospital and the Concord Plastic Surgery Group. I've been given the privilege to talk today about a very fascinating subject. At least I think it's fascinating. Hope you do too. I have a bit of a penchant for history, and I like to look at the surgeries that I do through a historical context. So today I'm going to be talking about the history of breast cancer, its surgery, and breast reconstruction. This is a story that's really tightly woven in the human fabric of disease. It's the story of medicine and surgery coming together, first to stave off mortality, and then to stave off psychological despair. It's because we lose the sense of wholeness when we undergo breast cancer surgery, and breast reconstruction is there to repair that. And I just realized I need to turn on my microphone. How's that? Better?
Much better. I was just going to try to flag
Sorry
something.
about that. So if I've given one of these talks before, and at that talk I did mention that I always start off all of my presentations with ancient Egypt. And that's because my minor is in Egyptology from the University of Chicago. And I think everything begins and ends in ancient Egypt. But really, that is a really good place for us to start. Ancient Egypt is an amazing land. It is a land of contrasts. And you can sit here and stand at the edge of the city and have one leg on the ancient plateau of Giza and the other in modern city Cairo. And this really reflects our story as well. On one hand, we have all the ancient history that we know about, and then we have nothing, and then we have our modern times. So it's very similar in that way. Also, our story starts in Egypt, in Alexandria, where Louis Leakey, I don't know, an anthropologist, pretty well known in the 1970s, he found Lucy, one of the oldest skeletons. He found in Alexandria, Egypt, a jawbone that was 2 million years old, and the jawbone had a lymphoma, which is a cancer of the lymph nodes within it. This was the first time that we ever saw cancer in anything before, and it taught us that cancer is not a modern disease. It is a very old disease. possibly one of the oldest that we've ever seen. So, wading through our history, we begin with the very first mention of breast cancer, and it happens to be breast cancer. In 1862, we meet Edwin Smith. You can see him here on the left-hand side. He's a funny guy. He's a scholar, possibly thief. He was an antique forger. He said he was a self-proclaimed Egyptologist. He went off to Egypt and bought a papyrus, some say stole, from someone, a character who was just as unsavory as he was. And it was this 15-foot long papyrus with crumbling edges and yellowed. And Edwin Smith, who didn't really have the intellect to actually decipher it, kind of forgot about it. And the information that it had was left for scholars to, was unknown until the 1930s. So when Edwin Smith died, it actually went to a museum, and it was discovered by James Henry Breasted. And I mention him because he is part of the University of Chicago and the Oriental Institute. But he was the one who deciphered this papyrus. It dates back to the Old Kingdom of Ancient Egypt, which is about 2600 BC. And the papyrus is thought to be a collection of writings about Imhotep. Imhotep is seen here. Imhotep was a Renaissance man of his time. It was from the Old Kingdom of Egypt. At the time when Egypt was booming, and he was a sculptor, an architect, and a surgeon. And when the Greeks came through 1,000 years later, they heard and read about the writings of Imhotep, and they actually made his image into their god of medicine, Asclepius. Asclepius is important to us because he's carrying the wand of medicine here, which is a stick wound round with a snake. And we still use that today. The American Medical Association uses it in their logo. So that dates back to Imhotep. So the surprising feature of the Edwin Smith papyrus is the fact that it has no magic, no charms, and no religion. It's the absolute absence of these things in this papyrus, which is amazing because when you look at ancient Egypt, all we think about is all the incantations for the dead and for the soul to move on. But none of that was in this papyrus. Imhotep was writing about wounds, about bleeding gums, about broken bones, about how to take care of facial fractures, and it was a very sterile scientific work. There were 48 cases in the papyrus, and under the 45th case, we see the first mention of breast cancer. It says there, it's a distinct disease, and it says in case 45, bulging tumors of the breast. I know you guys can't read that, but some writing, I can't read some hieroglyphics, and there it is. It says, if thou examine a man having bulging tumors on his breast, and findest that the swellings have spread over his breast, and that if you put thy hand upon his breast and find them very cool, there being no fever and no fluid. And then the description of the mass follows. It is firm, it's hard, it's dense, like a ball of wrappings. This is undoubtedly the first sign of breast cancer. And most every case in this papyrus was followed by some treatment, even if it was just palliative. It was poultices for wounds, honey for burns, balms. But in this case, underneath treatment, there is only one line, and all Imhotep says, there is none. So with that admission, the description of cancer actually virtually disappears.
I just want you
From.
to check the mic just to make sure is it now working?
Now it's on. It's weird. Sorry about that. Technical issues. So now we see a disappearance of the word cancer for thousands of years, really. We know that other epidemics were happening. There were plagues. certain things were decimating the population. Smallpox was coming through, and then it affected, we know that it affected Ramses V because there were mummies with smallpox scars upon them, typhoid, as well as, of course, tuberculosis, which came in back and forth and ebbed and flowed throughout time. I think it's the battery. Opens. It's much better, it's green instead of red. So, 2,000 years passed since the time of Imhotep. Before we see breast cancer again, and again, it's going to be breast cancer. It seems to be the one that is talked about the most in ancient history. This time, it's not about a surgical treatise. It's actually a personal account, and it's written by Herodotus, who is a Greek physician back at the time. And it's about a woman. Her name is Atossa. She is the queen to Darius the Great. She's also the mother to Xerxes I. Herodotus records her story. Atossa was besought with a lump in her breast, and it began to grow in size and became extremely painful. He said that the breast became red and swollen and bled. This was probably an inflammatory breast cancer that was affecting her. And it made her so distraught that she actually wrapped herself in with a sheet and shut herself away from the world. Well, there was a Greek slave by the name of Democedes that persuaded her to allow him to remove the tumor. The procedure was a success. And there, Herodotus stopped telling us the story. But the story actually doesn't end. The historical record then talks a little bit about her. And at the time, Darius, her husband, was going to plan to invade the east, Scythia. However, Democedes, the slave, he wanted to go home. And Atossa begged her husband to change his mind and instead invade Greece instead to bring Democedes home. So was this in thanks for her cure? We don't know. No one will ever be sure, but the Persian Empire did turn its eye from east to west and started the Greco-Persian Wars that followed. And so we can sit back and look back at time and think, was it Atossa's tumor that launched 1,000 ships and changed the history of the Western world? And so we fast forward once again through time, and we're going to see a number of other women who have been besought with the disease. This is Empress Theodore of Constantinople, queen of the Byzantine Empire. She actually died in 548 AD because of breast cancer. She decided, probably rightly so, not to have any surgery done to it. Queen Anne of Austria, she was the wife of Louis XIII. And then she took up the throne after his death and ruled all of France. She was diagnosed in 1663. She went through some horrific treatments for it afterwards. She had surgery, multiple bloodlettings. Poultices were applied to the wound with soap with arsenic. She succumbed to the disease 3 years later, likely due to metastasis. And then, of course, it lands on our own shores here. This is Mary Washington, George Washington's mother, who also succumbed to breast cancer in 1787. It's kind of apropos to think that our country's founding father's mother founded the Mary Washington Healthcare Hospital System in America. It's one of the oldest not-for-profit cancer treatment centers in the United States. The first ever in-person account of breast cancer, however, was with Fanny Burney, and she is a satirical writer in England, and she probably paved the way for Jane Austen, Pride and Prejudice fame. She recorded her mastectomy with a gut-wrenching honesty that's almost difficult for us to read. This was at a time before anesthesia, before pain medicine. And she said that 7 doctors showed up at her home that day. They were all dressed in black. And she writes, "When the dreadful steel was plunged into the breast, cutting through veins, arteries, flesh, nerves, I needed no injunctions not to restrain my cries. I began a scream that lasted unintermittingly during the whole time of the incision, and I marvel that it rings not in my ears still, so excruciating was the agony. The surgery took over 20 minutes. She did, however, go on to live for another 29 years. More often than not, though, women and men succumb to breast cancer. And so it was with a long-awaited relief and a collective medical sigh when we finally found an answer. 2 things came our way that really paved the way for us to really start conquering breast cancer and leading us into Reconstruction. The first, of course, is the triumphant day when Edward Morton and Horace Wells publicly demonstrated the use of anesthesia on a patient just south of here, down at Mass General, in October of 1846. This is the ether dome down at Mass General. It was the first form of anesthesia and pain relief that was administered to remove a mass from a young man's neck. So this opened up the floodgates of the surgical world, and now we can finally do longer surgeries and more intricate surgeries with patients asleep, not having to deal with the pain of undergoing any surgery. And it was this discovery of anesthesia that led to our first great of surgery. This is William Stewart Halstead. He's one of the most influential surgeons of American history. If you asked 10 sports writers who were the most important baseball players of our time, you'd probably get 10 different answers. Willie Mays, Roger Clemens, Babe Ruth. But if you asked 10 medical historians who was the most influential American surgeon, I bet you all of them would say William Halstead. He was the first one to start a medical school at Johns Hopkins. He gave us a better knowledge of anatomy. He insisted on sterile technique. He insisted on meticulous surgical care for our patients, as well as keeping excellent paperwork of before and after. So what he really brought to us was the first time of a surgical scientific method. In 1882, he performed the first gallbladder surgery in the United States. It was on his own mother, in her own kitchen. He also performed the first blood transfusion, and that was on his sister after she had given birth and was bleeding. Here he is, he's seen here, he's at the head of the table. There's Halstead. Interestingly, he's surrounded by students, residents, and then this is his head nurse, and she's wearing gloves. It was William Stewart Halstead that brought gloves to surgery. And the reason was because his head nurse actually had a rash. She was allergic to the carbolic acid that was used to keep the area sterile. And so he asked the Goodyear company to commission gloves, not only for her, but then for everyone else that was in the surgery as well. Incidentally, she became his wife later on. So Halstead brought many firsts to us. And he was the first to actually describe a mastectomy that patients could survive and did well postoperatively, meaning the cancer was gone. The Halstead mastectomy is an en bloc resection of tissue, meaning en bloc, meaning in one piece. So the entire breast tissue, as well as the pectoralis major and minor muscle, those are the muscles that are underneath the chest, were also taken. as were all of the lymph nodes within the armpit. This really was a radical mastectomy, and it unfortunately left wounds on the chest wall that were left to heal by secondary intention, meaning they were left to heal so that to close in on either side. Once this scarred down, unfortunately, it didn't allow women to move their arms very well, and oftentimes they would have a very swollen arm just because of all the lymph nodes that were taken. But it did leave patients alive. It was, unfortunately, very debilitating. Halstead, however, believed that this procedure needed to be this way and that we couldn't put any reconstruction there because then it would hide any cancer that was going to come back. Unfortunately, Halstead was wrong. The radical mastectomy maintained its importance in the United States all the way up until the 1970s. In Europe, however, they were starting to question whether or not it was necessary to take all of this tissue. But we still see some women today that have gone through this procedure. So when you see women coming in and all you see are the rib cage, that means that the muscles have been removed. This has been healing by secondary intention, that's all scar, and the movement to the arm is very difficult. Someone with less so disfigurement, but you can see there is very little way of doing a reconstruction when you have nothing left to reconstruct. So in Europe, they recognized the fact that this is a little bit radical. And they went back to the drawing room and were looking at the actual anatomy of the breast. And in the 1930s, we finally found that the breast is made up of skin, soft tissue, and then this is the breast parenchyma. This is a 1930s illustration of the breast, and this is a modern version of the breast, very similar. And we now know that this is skin, soft tissue, very different than what the breast is. And when you're in the operating room, you can actually see the difference between fat of the breast and fat from the soft tissue above it. So this is skin, which is a different organ, and this is the breast. And the muscles are a different organ as well. So when we start separating out which organs are what, and we remove only the diseased organs, then we have enough tissue left over to start thinking about reconstruction. The first breast reconstruction happened in late 1890s, 1900, by this man, Cherney. Cherney was a surgeon, you can see, there he is, who came across a patient, and she was an opera singer. And she didn't actually have breast cancer, but she had chronic mastitis, which is inflammation of the breast tissue. And it caused her breast to get swollen and sore, and there would be pus that would drain out from it and then would scar in. So she had a very firm, hard lump on her breast, and he needed to do a mastectomy to remove it. She was concerned because she, as an opera singer, she had to wear costumes all the time, and she was worried that that asymmetry would be seen when she was working. So she was actually also very lucky because she had a large lipoma, which is a fatty tumor. It's a benign fatty tumor in her hip. And so Cherney decided he's going to take that lipoma. He took that out, and he put it into the defect that was in her breast, thus recreating the breast. We don't know how long it lasted. We don't know if it was firm or hard, but from what we gather, we think that she did all right and continued her career. Moving along, the first person who actually started looking at how to stop the wounds that occurred after doing that radical mastectomy was going to be a man, he's an Italian surgeon by the name of Tanzini. And he was the first one who actually described a latissimus flap, but he didn't actually know that it was what we now know as a latissimus flap. But he did know that you could take tissue from the back, swing it underneath the armpit, and place it into the breast. And this was the first time the latissimus flap was described. Unfortunately, in 1906, medical information was not disseminated like it is today, and this was lost for 70 years. We didn't know about the Latissimus flap. And actually today, it's still one of the workhorse flaps that we use. As you can see, oh, here's a picture of the Latissimus flap after he had finished. So he took that tissue from the back over to the front and sutured it in so that she didn't have any scar tissue to develop there and could move her arm afterwards. It was not a breast reconstruction, it's just filling in the wound. But like I said, this is one of my patients, and utilizing the true Latissimus flap, here she is. She came in, she had a very bad cancer, and she was in her 40s on that right side, underwent a modified radical mastectomy on that right breast with radiation. Because she had a very bad cancer, she decided to take the other side off as well prophylactically. So now we're going to go back, we're going to reconstruct both this breast and this breast. I'm utilizing the back muscle, the tissue on top of it. Here's the back muscle, here's your latissimus muscle. This is the skin paddle that runs on top of it. We're gonna take that on either side, put it in place, and recreate her breasts. Those nipples are recreated from the back tissue from her back. Going back to the 1920s, Sir Harold Gillies was also, he's one of our greats of surgery, developed other types of flaps to try to reconstruct this area. But really he was utilizing flaps that he came up with after patients came back from World War I who had a lot of head injuries. And he described something called a walking tubed flap. And he utilized those in the face in the 1920, 1919, and then he did it in the 1950s on a woman. So this is a walking tubed flap. Again, before the time that we actually knew how the anatomy runs in the soft tissue and on in our bodies. But if you have a woman here, she's got a large breast, she had a mastectomy on this side. So he's gonna borrow tissue from this breast. He divides that breast into two, so he creates a tube out of the bottom of the breast there, and he lets it sit. About 3 months later, goes back in, he's going to remove it from here and swing this up into here. So here it is, it's swinging up into here, and he sutures it into this place. So now, we're gonna let that sit for a few months, because the blood supply is going to be coming in from here to supply this, so that you can take it off of its pedicle here and insert it into the breast. This is called a walking tubed flap. And it gave her a fairly good reconstruction for what they were doing. The problem was, it took 9 months to a year, and you're walking around with this tubed flap being moved around, and the risk of it actually failing was quite high. So it wasn't a great reconstructive method. So again, we need to go back to the drawing board, and we did. It was actually not until the 1970s, 50 years ago, when Fouad Nahai and Mathis really went back into the cadaver lab and looked at the blood supply to the muscles and how they affected the skin. And they wrote this book called The Clinical Atlas of Muscle and Muscular Cutaneous Flaps. This book is in probably every single one of our plastic surgeons' office. I know it's in ours. It is one of the great books that have ever been written. But what they discovered is that our muscles come in basically 5 types. And it all has to do with the blood supply to the muscles. So type 1 muscle, for example, the tensor fasciae lata, that is a muscle that's down on our leg. It has one single pedicle that comes in. So one single big blood supply runs in here. And then blood percolates up through that, little arteries and veins, to supply the skin and soft tissue on top of that muscle. So what that allows is that if you know that the skin is going to be okay, you take this muscle and you can swing it anywhere, and the tissue on top will remain alive because it's all coming in from this one pedicle. There are other muscles like the gracilis flap that we use. It's got one good pedicle and then two smaller pedicles. So you could actually divide this in half and use just this top part and swing it around. A type 3 muscle, like the gluteus maximus on the buttock, or the rectus. They have two major pedicles, one from the top, one from the bottom for the rectus. In the gluteus, they come in from the same side. And then my favorite muscle is Latissimus dorsi muscle, it's the back muscle. So here's this major pedicle, the thoracodorsal arteries, artery and vein, and then here are these little smaller ones. So you can swing this guy on this pedicle, and the skin and soft tissue on top of it will be fine. Knowing this information, Dr. Karl Hartranft, 1984, this is how recent this stuff is. 1984 came and actually developed the first Tram flap. And that is a well-known flap. It's, if you go on the internet, it's known as the tummy tuck flap out there. It's not really a tummy tuck, but it's taking tissue from the abdomen and putting up it into the breast. So here, this is a Tram flap, utilizing the rectus muscle. We have two rectus muscles. There are 6-pack muscles. Utilizing that, taking off this tissue, swinging it underneath here, and putting it up into the breast to recreate it. And this is one of my patients utilizing a Tram flap for reconstruction. She was young, she was in her 30s. She really didn't want an implant. And here she is, the breast cancer is on the right side. She has some asymmetry just to start with. This is the scar from the lumpectomy that shows that she had a fairly invasive cancer with a lot of ductal carcinoma in situ. So her entire breast was basically cancer. This is the markings for the procedure. Here's her rectus muscle. This muscle is going to be providing for this tissue that's down here, and it's going to be swung up into this space. You can see this blue-black line. That's where my breast surgeon needs to cut. So they cut there, and they're going to do the mastectomy through these incisions, and then I'm going to reconstruct from there. On this side, we're going to do a breast lift, just so that we can get a little bit better symmetry between the two. So here she is about 3 months later, 2 surgeries later. The incision down here, around her belly button. You can't really see, but there's a little bit of a blunted inframammary fold. That's where that muscle is going underneath here and then providing the substance for her breast. The problem with breast reconstruction in this method, by using our muscle and moving it around, is the fact that a Tram flap can be very debilitating afterwards. It provides a beautiful reconstruction, but it takes the abdominal muscle, which is our core muscle, and so when you take both of them, actually those women can't do a sit-up. So when they get out of bed, they kind of have to roll out of bed. So by losing the core musculature, you're losing a lot of the strength of your upright posture. And so, again, going back to the drawing room and figuring out how can we do these reconstructions without having to move the muscle. And so microsurgery came about. And that's where we do surgery underneath the microscope in the operating room. We dig down through the muscle. We try to see where those little arteries and veins are percolating up. Remove those, dissect those, and then take that tissue and move it into the area that we're trying to put it in. And then we have to attach artery and vein to vein. Bunke is the father of microsurgery back in the 1990s. He actually did the first microsurgical repair on a rabbit's ear, and the little vessels were 1 millimeter in diameter. This is not the rabbit that he did that on, but nonetheless, this is a microsurgical anastomosis. You can see here, this is the soft tissue in this, where they moved it from. Here's a little vein, artery, into the donor site, connecting that vein and connecting that artery. You can see the little sutures there. They're 9/0 or 10/0 silk or nylon that's smaller than a hair that you were using to reanastomose those two areas. This was all great, and it started opening up the way for autologous or tissue that we use for breast reconstruction. The deep flap became the new workhorse, and it still is a workhorse for taking tissue and moving it somewhere. So it's just like the Tram flap. So we're still using that rectus muscle. Here's that rectus muscle, but here we go. We're digging down through that muscle. We're gonna try to find the artery and vein that's supplying this soft tissue and putting it into that space. You have to take out a rib, either the third or fourth rib up here, so you can find the mammary vessels, so you can bring those two together. The gap flap. This is same concept, different areas. We're always trying to find places on the body that we can take tissue and move it around so that we can reconstruct the breast. Here we're using the gluteus maximus muscle, also a type 3 muscle. Remember, it had those two good blood supplies. We're taking that tissue from here. The problem is, it really does leave a significant asymmetry on the back end. The Pap Flap, this is the profunda artery flap, where we're taking tissue from just right underneath here. The problem here is that it's an incision in the groin, and you don't have that much tissue to work with, so oftentimes you have to have a small breast that you're reconstructing. Also, this incision in the groin can get infected pretty easily. And this is the tug flap. So again, over and over again, we're trying to find places where we can take tissue from one part of the body and move it so that we can do a reconstruction. When these work, they're great. Unfortunately, they don't always work. When the artery goes down, the whole flap can die, which requires another surgery, possibly 2 or 3 more surgeries. Even if the artery doesn't go down, sometimes all of it doesn't get perfused, so you get something called fat necrosis, dead fat in there, and it gets hard and firm, and then you're going back to remove some of that dead tissue. It's a long surgery, 8 to 12 hours. There's ICU time afterwards. Women have to spend a couple days in the ICU, then they have to go and stay in the hospital for about a week, and then at home they're still recovering for another 2 months. So there's a lot involved with these types of procedures. So even since the beginning of time, we've been always looking for other ways that we can do breast reconstruction instead of using something on our own bodies. Even at the turn of the century, they were trying something. And the first thing that we were always looking for is something that can be injected into the breast. Well, paraffin was injected for 20 years, paraffin wax. Crazy to think that it was a procedure that was done for 20 years, even though it had really bad outcomes. A lot of infection, the thing would bubble up, it would be extruded from the body. All kinds of other things, glass ball, wool, foam, polyvinyl vicryl, all kinds of things were tried to put into the breast, obviously with disastrous outcomes. Even free silicone was tried to be injected, and we still see some of the effects of that today. The story, though, comes to a full circle in 1960s, when we finally started figuring out how to make a device that we can safely put into the breast for reconstruction. And that story involves 2 men and a dog. Henry Cronin, Frank Gerow were the ones who actually discovered the breast implant. And this is their dog, Esmeralda. Well, not their dog. I think it was Cronin's, actually. Her name was Esmeralda, and she'll play a role in this. So it was actually Cronin who had gone off to New Orleans for a medical conference, when we actually could go to a medical conference and talk to each other. And he met a guy from Michigan, and then over lunch they were talking. This guy from Michigan was like, hey, there's this new company that just started in Michigan. Its name is Dow Corning. And they have this new substance that it's viscous and sterile and it's malleable. And I think that maybe it could be used somehow for as an implantable device. And Cronin remembered that conversation and went back home, and he goes to work, and he's with Gerow. Gerow is a Canadian surgeon, and he was his resident, and he's kind of a charismatic guy. And they were in the burn unit, in pediatric burn unit, and Gerow was carrying back a bag of blood. It was an IV bag of blood. And the thing that's amazing about that is because IV bags just came out in the 1960s. They used to be glass bottles. So he's carrying around this thing. He's like, hey, take a look at this. And I'm sure he was joking when he said It looks kind of like a breast. Well, Cronin put the two together. He thought about that viscous fluid that surgeon told him about that came from Dow Corning, and he put it together with that IV bag that they were carrying around that blood in, and he thought, maybe we can make an implant. So he calls Dow Corning, and he talks to Silas Blakely, the guy who ran the medical department at Dow Corning, and he said, can you make these for us? And so they started churning them out, small, medium, and large. And they took the small one, and they implanted it into Esmeralda, our dog. And the procedure was a sort of success. She did fine, but she did chew out her sutures a few months later, and the implant fell out. But it was still deemed a success at the time. In comes Timmy Jean Lindsay. So she is a woman that had a tattoo removed. It was a rose tattoo on her chest. And she went in to see Cronin and Giroux just for her post-op stuff. And Giroux approached her and said, hey, do you want a breast augmentation? And she said, no, I want my ears pinned back. And he goes, okay, we'll do that too. So she goes in for surgery. She gets her ears pinned back because that's what she really wanted. And she said, okay, let's go ahead and do a breast augmentation too. So she is the first woman who ever had a breast augmentation. And here she is. I'm not sure if she's still alive. She may have died recently, but she died with her breast implant. She was super happy with them. She always went around, and whenever she was at an interview, she goes, I was the first. I was the first. So that was the first breast implant that was ever placed. The implant back then in the 1960s was a silicone fluid. It was more of a liquid, and it had this Dacron patch associated with it because they thought that when you put it in, it had to stick to the chest wall. Well, this thing took off like wildfire. When they went to conferences, the rooms were bulging with surgeons listening to how we can do any type of surgery with these types of things. And very soon it went into the reconstructive field, and now it is one of the best devices that we've ever seen for breast reconstruction. Obviously, we've gone through many permutations of the breast implant. We're on our 6th generation of implants right now. And the silicone is a polymer that has now been cross-linked to such a way that it's actually considered a solid, but it feels like a liquid. So if you take the shell off of a breast implant today, it will still stay in its shape. Nowadays, women have a lot more choice in how to do a reconstruction. And actually, 10 to 1, they choose to do reconstruction with implants or other materials like this rather than autologous tissue. Not that that's bad, but we now have many more things in our pocket for doing breast reconstruction. To make things even better, after we do an implant type of reconstruction, we've got tricks up our sleeve. Now we've got fat grafting. Remember when in the 1900s we were injecting paraffin wax? Well, now we can inject fat, our own fat, patient's fat, that we can harvest safely and then re-inject back into the breast to contour out certain reconstructions. And this is Sidney Coleman with his smirky look. He actually didn't invent fat grafting, but he marketed it. So this is fat grafting in one of my patients. Here she is, she's after a reconstruction. Several years later, she came back. You can see her implants are in place, but she's got some wrinkling up there. It doesn't quite fit her chest wall anymore. They've kind of gotten a little bit smaller, less wide. And here she is, you can still see that wrinkling. So borrow some fat from the abdomen, actually take the fat from the abdomen, and inject it back up into the breast tissue, into those mastectomy flaps to smooth out those contour irregularities. So here she is several months after surgery. You can see the difference. It just makes things look just a little better. And again, contour irregularities here, and you can just see it's smoothed out and kind of widened the breast up. Same thing here. This is a bilateral mastectomy. So this is after the mastectomy. She had a pretty significant asymmetry preoperatively, so that's why this one was lifted, just to see if we could get her nipples to be a little bit better. But on this side, you can see where that implant ends. So you have a little divot. You can see it here. So taking that fat to smooth that out to make it better. So what else do we have nowadays? We've got better tattoo artists. This really is that final little sine qua non in breast reconstruction. And this is Vinnie Myers. Vinnie Myers is located down in New Jersey, and he's actually like the Michelangelo of three-dimensional nipple tattooing. This is a nipple tattoo afterwards, and this is one of my patients who actually went down to Vinnie, and this is his tattoo. This is not a reconstructed nipple. This is flat. And he even put in little Montgomery glands, and then you can see, you want to touch that and be like, oh my gosh, that's flat. But it doesn't look that way. So when you put a nipple on a reconstructed breast that has been lost, it really brings your eye to the nipple and it makes everything look like it was normal. If you don't have that, it always looks a little abnormal. And by putting that on there, you kind of hide the scars, and it's a trick of the eye, a trompe l'oeil, and you don't see that you had surgery before. So that when women look at themselves in the mirror, they don't have to be reminded every day, oh, I had surgery there, because the mind is tricked. So I'm just going to go through the last few minutes with a few surgical cases that I've had through the years of breast reconstruction. This is a patient. This is interesting. Somehow the slides have screwed up, but you can see this is the patient here. Ignore this. This is supposed to be on the other page. But she had a modified radical mastectomy. So we've lost a lot of tissue here. So I took the Latissimus flap and a small implant in there to recreate her symmetry. Hold on for one moment. I don't know why, but by putting it in here, the computer has made these. I guess I should have checked, but the flaps are out of order. I'm actually not sure what to do right now because it's caused them to go out of order. Let's see. I think it's because it's running a different program than the way mine was set up. So you can't really see the befores and afters very well, which is unfortunate. Because one before is on one slide and the after is on a different slide. So here, this is a before. Again, same type of thing. Pretty bad mastectomy defect. And then the after is here. Lifted this breast, reconstructed this breast, put on a new nipple here. This is the scar that you get from a Latissimus flap. This is going to be a before for the next case. Oh my goodness. I'm not sure why that's happening, but the befores and afters are screwed up. Nonetheless, this is a reconstruction here with just implants and some fat grafting afterwards, giving her a nice shape. The before is here. This is her after. We still don't have a nipple tattoo on there yet, but you can see how it's a process. Breast reconstruction takes several months before it's completed, and usually about 2 to 3 surgeries. The first surgery is your big surgery to get a mound back on there. The second and third surgeries are just kind of that artistic touch. Put in a little fat grafting, reconstruct a nipple, and then finally, I always urge all of my patients to try to get a nipple tattoo. Again, this is not this patient, but after a breast reconstruction just with implants, it actually gave her a breast lift. This is her before. If you draw a line here, you can see the nipples right at that inframammary fold. And afterwards, by just doing the reconstruction, there's that scar line for her breast cancer. It actually lifted her breast somewhat, and she was quite happy and never really wanted to lift. The thought in breast reconstruction today is that we want our patients to look like they've had a breast augmentation or they've had nothing done at all. That is really the key. So it would be great to have breasts that look even better than what they were beforehand. So this is a before, and here she is after mastectomy done through an inframammary fold incision and implants placed afterwards. Again, this is an after procedure. Here she was before. You can see that the implants lifted and the mastectomy lifted up her breast so that we didn't have to do anything to it. It looks like a breast augmentation. So where do we go from here? Really screwed up my slides. Kind of bummed. The future is pretty bright for breast reconstruction. We're seeing more and more techniques for breast surgery out there. We're doing less invasive types of procedures, more skin sparing, more nipple sparing. Radiation is much better. It's not as devastating anymore. It doesn't harm the tissue as much anymore. And now we've got better and better implants. I mean, our implant companies are still making new implants for us. Less viscous, more fluid-like natural feel, longer lifespan. We've got better fat out there. And I think in the future we're going to be seeing some synthetic fat that we'll be able to take off the shelf and put in there and utilize so that we don't have to even do that liposuction technique. So there is a lot of stuff out there for the future of breast reconstruction. And thank you very much. I'm sorry that my last slides were kind of screwed up. This is our team.
Any questions for Dr. K?
I was just curious about, you mentioned the recovery time for someone that has the flap procedure.
Mm-hmm.
What is it when it's an implant?
Usually they're back up on their feet. We often try to do reconstruction at the same time as the breast cancer surgery, but not always. So they stay overnight because of the breast mastectomy, not because of the reconstruction. So
Right.
they go home that next day. They
Yeah.
could technically go home that same day. And then I want them up walking around, but no heavy lifting, pushing, pulling, any of that for 4 weeks after surgery. But they're up moving around and they can actually get back to work within 1 to 2 weeks. The major recovery is the mastectomy and the psychological aspect of the mastectomy rather than the reconstruction.
Any other questions for Dr. K? Dr. K, thank you so much for a great presentation. It's always so enlightening, and we love how you interweave your history and Egyptology as well. Thank you, everyone, for joining us today. We really look forward to when we're able to invite our donors and our special friends back in for our monthly lunch and lecture series, and hopefully that time will come soon. Please join us on Friday, April 9th, when Dr. Marangos from Concord Endocrinology and Dr. Melissa Hoyt from Concord Surgical Associates will join us talking about their collaborative efforts in treating different kinds of thyroid issues. As a reminder, you have the ability to access our What's Up Doc presentations via the hospital's Facebook page, and they are also uploaded to the hospital's YouTube channel. Once again, we want to thank the Walker Lecture Fund for being our new sponsor. We wish everyone a safe and healthy time. Have a great weekend. Enjoy the nicer weather.